I'm going to start off with pancreatitis. Acute pancreatitis, what are some of the etiologies? Well, most commonly it's going to be due to alcohol and cholelithiasis. Less common etiologies include hyperlipidemia, various medications, following techniques such as the ERCP or surgery. There are infectious etiologies, including mumps, measles, and various viral etiologies, and then a familial form. Now, by far, most cases will be mild, but up to 20% of cases you can have complications associated with organ failure. Now, some of you might have heard about the Atlanta classification for acute pancreatitis, which is what is being encouraged even in imaging classification technique. This was first developed back in 1992 and then revised subsequently in 2008 because of an increasing need to develop uniformity in describing pancreatic and peripancreatic fluid collections. So I'm going to try to go through this with you in an easy way that you can remember. So under the revised Atlanta classification, remember that there are two morphological types. The interstitial edematous pancreatitis, which tends to be a less severe form, and then necrotizing pancreatitis. There are various fluid collections that can develop in association with each of these morphologic types, okay? And this is divided according to a time interval related to the onset of symptoms. So within 4 weeks of symptom onset, you can see from interstitial edematous pancreatitis, you can develop what's called APFC, or the acute peripancreatic fluid collections. All right. After 4 weeks, the terminology is pseudocysts, which you are all familiar with. Okay, everybody with me? Now, necrotizing pancreatitis has associated fluid collections as well. And from necrotizing pancreatitis, if you are within 4 weeks of onset of symptoms, then you can develop what's called post-necrotic pancreatic fluid collections, PNPFC. All right. If it's after 4 weeks, then it's walled-off pancreatic necrosis, the WOPN. Okay? So this is, I think, a fairly easy schematic and framework for you to remember under this new revised Atlanta classification. Now, there's modifiers that you can use for those fluid collections that occur after 4 weeks of symptom onset, and it can be infected or it can be sterile. Okay, so the modifiers for a pseudocyst or a walled-off pancreatic necrosis is infected, which used to be called abscess, or sterile. Now, this was from a paper that was published just last year, and I think it goes through for you in a bit more detailed descriptions of the different types of fluid collections. So the acute peripancreatic fluid collection, the APFC, again, within 4 weeks of onset of symptoms, and there's no fibrous wall, okay? The post-necrotic pancreatic fluid collection, remember this is in the setting of necrotizing pancreatitis, is also within 4 weeks of onset of symptoms, but you can have loculated fluid, and portions of the pancreas will not enhance. And then you have the walled-off pancreatic necrosis. This is greater than 4 weeks after the onset of symptoms, associated with pancreatic necrosis, and then you can develop what's called a non-epithelial or fibrous wall. All right, and I have examples to show you. And here you can see no loculations, whereas in the post-necrotic pancreatic fluid collections, you tend to get these little loculations. And then in the walled-off, you have a clear fibrous non-epithelial wall. Now, in the revised Atlanta classification, they also discourage the use of these two terms, abscess and phlegmon. So you can have a infected pseudocyst or infected walled-off pancreatic necrosis, but you should not use the terminology abscess, okay? Now, what are some of the features of a pseudocyst? We said that it takes at least 4 weeks for it to develop. You should have an imperceptible wall with no enhancing internal contents. Debris can be present, though, and you have to distinguish that. Typically, you use the non-con to help you determine enhancement. And it can be up to 30 Hounsfield units. Calcifications of the wall will be uncommon, and they can occur anywhere, as you know. This is another complication of acute pancreatitis, and what you're looking for is a rounded structure that enhances to the same degree as the aorta, okay? And this is pseudoaneurysms of the splenic artery. Now, moving on to chronic pancreatitis. This is where you have permanent structural and functional damage to the gland. By far the majority of cases are due to alcohol rather than gallstones. Less common etiologies include hyperlipidemia, hyperparathyroidism, and pancreativism. Remember that chronic pancreatitis is a risk factor for the development of pancreatic adenocarcinoma. And then there are two subtypes of chronic pancreatitis that you should also be aware of: groove pancreatitis and autoimmune pancreatitis. And I'll go into that a little bit more in just a second. Some of the imaging findings of chronic pancreatitis, you're all familiar with the calcifications of the gland. You can also develop these intraductal stones. Most cases will have an atrophic small gland, but in some cases you may have a diffusely enlarged or focally enlarged gland. The double duct sign, where you have dilatation of the pancreatic duct and dilatation of the bile duct due to fibrosis involving the pancreatic head. And then all of these, the pseudocyst, pseudoaneurysms, are similar to what you would find with acute pancreatitis, and then thrombosis of the splenic vein or portal vein. Now, groove pancreatitis, as I mentioned, is a form of chronic pancreatitis. The typical clinical presentation is that of a middle-aged male with a history of alcohol use who presents with abdominal pain, nausea and vomiting, and may or may not have jaundice. Now, the typical finding on contrast-enhanced CT is this hypodense lesion that sits right in what's called the pancreaticoduodenal groove. You may see delayed enhancement, and in more severe cases with chronic inflammation, chronic irritation, you can actually develop what's called cystic dystrophy that involves typically the medial wall of the duodenum, and you'll see associated cysts in this area. When you biopsy these areas, all that you'll find is fibrous tissue. So again, just this sort of ill-defined, hypodense soft tissue that sits in the pancreaticoduodenal groove. And this schematic, this graphic, basically shows you that the pancreaticoduodenal groove is demarcated by the pancreatic head medially, the second duodenum laterally, and then the common duct posteriorly as it sweeps back. And again, just this ill-defined soft tissue that sits in this area. And this is just an example on T2-weighted MR where the patient has demonstrated these duodenal cysts. And again, it's along the medial wall, and it's due to this chronic irritation and chronic inflammation. The second form of chronic pancreatitis you should know about is autoimmune pancreatitis. Now, in contrast, here in this patient, you can see, again, it's an older male who presents with really nonspecific presentation of something going on with the pancreas, all right? Abdominal pain, jaundice, weight loss, but there's no history of alcohol use. Remember that autoimmune pancreatitis is part of a systemic autoimmune disease. So diagnosis can be made if you look for this specifically. Increased levels of serum IgG and specifically IgG4. So you have to remember this diagnosis in order to order these. What does it look like? Well, the most common presentation will be diffuse enlargement of the gland with a halo of low density. And I think that you can see this rim of edema. Also, you can see this on contrast-enhanced MR. It's important to diagnose this because treatment is with steroids and is quite effective in these patients. And this is from a paper from radiology that shows you the different forms. Again, the most common is just this diffuse enlargement of the gland. It's been described as sausage-shaped, and you see this rim of low density representing edema. You can also have a focal form where it involves just a portion of the pancreas and typically of the pancreatic head, or multifocal, and this is the least common type. And again, even with the focal and the multifocal, you should see this rim of low density. And here's just an example, again, of the diffuse form of autoimmune pancreatitis, where you have a markedly enlarged, diffusely gland with this halo of low density. Now, after steroid therapy, you can see the gland shrinks back to its normal size and you've lost that low-density rim. Okay, let's move on to congenital anomalies. And the first one is pancreas divisum. This is where you have failure fusion of the dorsal and ventral pancreatic buds, so that the body and tail of the pancreas is now drained by the duct of Santorini through the minor papilla, and the head of the pancreas is drained by the truncated duct of Wirsung through the major papilla. There's an incidence of 5%. It is a cause of recurrent pancreatitis, and when that occurs, it typically will involve the body and tail, because remember, now the largest part of the gland is now drained through a smaller papilla. CT or MRCP can be diagnostic. ERCP may be obtained, and that is always diagnostic. So just to show you what this looks like on ERCP, typical appearance where the gastroenterologist has injected the major papilla, and what you see pacified is the duct of Wirsung. Here you have normal branching structure at the tip of this truncated duct of Wirsung, and that's how you know that this is pancreas divisum. In contrast, what about this case, where you have filling of the duct of Wirsung, abrupt termination, but absolutely no branching? And this is the typical appearance of pancreatic adenocarcinoma. On CT, what are the findings? Well, you see an enlarged duct of Santorini, and it comes straight over to the minor papilla. Here's the duct of Wirsung, which is truncated, emptying into the major papilla. This was written up, and this is there's actually a sign called the dominant dorsal duct sign, where again it just emphasizes that this duct of Santorini, which is your dorsal duct, is larger than your duct of Wirsung. Now, annular pancreas is where you have a bifid ventral pancreatic bud. So what is left is this band of pancreatic tissue that encircles your second duodenum. Now, about half of patients will present in the neonatal period with obstruction with the classic double bubble sign. However, half will present as an adult, typically with periampullary ulceration, but also with acute pancreatitis. And again, CT currently or MRCP is often diagnostic, and we don't need to do ERCP for this. So the finding on ERCP, just to show you, inject the duct of Wirsung, and here you'll see that the duct actually takes this dive around the scope, which is located in the second duodenum, before it crosses midline. So it's encircling the second duodenum. On upper GI, what you'll see is focal, well-defined narrowing of the second duodenum due to the pancreatic tissue that's encircling it. And again, here on CT, you can follow the duodenum straight into the middle of the pancreatic head. Make use of your MPRs. So on sagittal and coronal, you can clearly define the duodenum that traverses through the pancreatic head. And here it is on the coronal. What about this case, where when you look at it, there may be concern, you have a hypodense mass-like structure sitting in the pancreatic head. You might call this adenocarcinoma. Well, if you give positive contrast, you think about annular pancreas, you can clear this right up for the patient. This is just annular pancreas. Okay, let's move on to adenocarcinoma. A little bit of the epidemiology. It is the fifth leading cause of cancer deaths in this country. You can see it represents 90% of pancreatic neoplasms, tends to occur in older men. There is a preference for the pancreatic head. You can see that in spite of improvement in technology and attempts to improve diagnosis and detection at an earlier stage, we've had limited impact, and 5-year survival is still at less than 5%. And 90% of cases are unresectable at the time that we diagnose it. What is the signature appearance of adenocarcinoma? You're all familiar with this. On contrast-enhanced CT, a hypodense mass, typically in the head. The double duct sign, again, where you have dilatation of the pancreatic duct beyond the level of the mass, and dilatation of the bile duct, which would be above the level of the mass. Often you may see also associated atrophy of the gland, again, beyond the level of the mass. On ERCP, coronal MPR CT, double duct sign. Here are the strictures, right, involving the pancreatic duct and the bile duct with dilatation beyond and nicely correlated on the coronal MPR. Hypodense mass, atrophy of the gland beyond, and also dilatation of the duct beyond. Now, can you find the adenocarcinoma in this patient? We know that there's something going on in the head because we have a markedly dilated pancreatic duct, we have biliary ductal dilatation and large gallbladder, atrophy of the gland, but can you find the adenocarcinoma? I think it's very tough. And in up to 10% of cases, the lesion is actually isodense to the rest of the pancreatic parenchyma and very difficult to detect. These cases tend to have a better prognosis. In contrast, there is this infiltrative form whereby the time the patient presents, yes, you already have Mets in this case, but there's just this diffuse infiltration of the gland. And this is uncommon but carries, obviously, a worse prognosis. You should be familiar with the T&M staging classification of pancreatic carcinoma. Remember that what separates T1 and T2 is just size, right? So less than 2 cm, greater than 2 cm. T3 is where you have local direct extension to adjacent tissues. T4 is advanced direct extension, including to the large artery celiac and the SMA. And this is just a graphic to show you the same. What the surgeons want to know is the lesion unresectable? And these are the criteria. If you have a very large lesion measuring greater than 5 centimeters, that will make it unresectable. If you have invasion of adjacent tissues or organs, except for the duodenum, which can be resected in a Whipple. If you have occlusion or encasement or involvement of your arteries, the celiac or the SMA, encasement of the aorta or IVC, invasion, I have plus minus for portal vein and SMV because it depends on the degree of invasion. And if it's a lesser degree, some surgeons will go in and resect and perform venous patching. And obviously distant metastatic disease. And here's just an example, clearly unresectable, where you have encasement of the entire celiac trunk and the branch vessels. Here's the SMA, completely encased. The coronal MPR actually shows very nicely the length of involvement. Now, there's a sign also of unresectability called the teardrop sign, where you have tethering of the SMA or SMV typically, and it can be posteriorly, it can be laterally, but this is a sign of an unresectable lesion as well. Perivascular cuffing can also occur, so even without the Mets, if you saw this sort of soft tissue that parallels branch vessels or even the celiac or SMA trunks, this is a sign of unresectability. Now, what's the differential diagnosis? What can mimic pancreatic adenocarcinoma as a hypodense lesion in the pancreas? Well, metastatic disease, right? Neuroendocrine tumors, your islet cell tumors, are typically hypervascular, but when they become large and they can become necrotic, they can appear low density. Lymphoma, if you have low density tumor from an adjacent organ that invades the pancreas, can mimic adenocarcinoma. And then benign entities such as focal fat, focal pancreatitis, and then necrosis. Let's move on to our cystic pancreatic tumors. They're not common. They only represent up to 10% of all pancreatic malignancies, and yet we tend to talk about them quite a bit. The ones that I'm going to discuss in a little bit more detail are the ones that I have highlighted in yellow. So starting off with microcystic adenoma, and this is your serous adenoma. These are benign. There is a female predominance of 4-1. Tends to occur in an older female age group, so this has been described as the grandmother lesion, okay? There is no preference for any portion of the pancreas. About a third will have this central calcification associated with a stellate scar. The classic teaching is that you'll have multiple cysts, and they're smaller, so numbering greater than 6, but measuring less than 2 centimeters. The classic appearance is this honeycomb appearance because of the innumerable cysts. They do contain glycogen, and there is an association with von Hippel-Lindauer syndrome. On cut section, this is what you see, the central scar and innumerable tiny cysts. And you can imagine that this would, with enhancement of some of the cyst walls, would cause that honeycomb appearance. Just to show you two different patients with microcystic adenoma, you can see the central calcification, multiple cysts. These are a bit bigger than in this patient where you do see that honeycomb appearance, but they can be up to 2 centimeters. Again, central calcification, central stellate scars demonstrated nicely enhancing in this patient with the multiple tiny cysts. Now, in contrast, mucinous cystic neoplasm is the one you don't want. It's frankly or potentially malignant. There's a higher female predominance, but at a younger age. So this has been described as the mother lesion, okay? And there is a preference for the pancreatic tail. Calcifications, when they occur, less commonly, 15%, are rim calcifications. And the classic teaching is that there are fewer cysts, right? So less than 6 in number, but they tend to be larger, so greater than 2 centimeters. And obviously they contain mucin. On cut section, this is what you see, are these large cysts. You can see mural nodules as well, and the mural nodules will enhance, on contrast enhanced CT or MR, as will the cyst walls. Now, when you see calcification, again, as I mentioned, 15% of cases tends to be peripheral, rim. This has actually been found to be a predictor of malignancy. So if you see the rim calcification, that's a bad sign, okay? Higher likelihood of being malignant. And here's just a large unilocular mucinous cystic neoplasm. And if you look very closely back here, there is a bit of peripheral calcification. Now, solid and papillary epithelial neoplasm, or your sapin tumor, this is an uncommon and considered a low-grade malignancy. However, it's got a fairly good prognosis because once you resect it, it's considered cured. Tends to occur in younger women, and you can see a mean age of 25 years old, so this is called the daughter lesion. These tend to be fairly large with a capsule, and they contain areas of hemorrhage and necrosis. So just to show you, you have a whole spectrum or a range in the appearance of these sapin tumors. And yes, they can be cystic, right, where you have the central necrosis, fairly large. But in this one, where it's also a sapin tumor, you can see that there are very small areas of low density, and most of it appears solid. Okay. This is from an AFIP study that showed you, again, mean size very large at 9 centimeters. Older literature demonstrated a preference for the tail. However, recent studies that have included meta-analyses and looking at more of these lesions actually show that there is no particular preference for any portion of the pancreas. Look at this, 100% will have hemorrhage, about a third will have calcifications, and then fluid debris levels may also be a feature of this tumor. On T2-weighted MR, you can see the fluid debris level here, focal areas of necrosis and areas of hemorrhage interspersed within a large encapsulated mass coming off of the pancreas. And this is on cut section. Again, hemorrhage, areas of hemorrhage, and encapsulated. Now let's move on to IPMT, which is the intraductal papillary mucinous tumor, also known as mucinous ductal ectasia. This is a range of histologies from benign epithelial hyperplasia to frank carcinoma. Tends to occur in older women. Now, there are 3 different types of IPMT that you should know about. The main duct type, and this can involve the main pancreatic duct either diffusely or only a segment of it, involvement of the branch ducts, or you have a combined type that involves both. ERCP is diagnostic, and what you'll find is a patulous, wide-open papilla with mucin pouring out of it. If the gastroenterologist can get the scope into the duct itself, they'll find mural nodules. The differential diagnosis for the main duct type, typically with diffuse involvement, is chronic pancreatitis because you'll just have dilatation of the main pancreatic duct. However, in the main duct IPMT tumor, you won't have the other findings of chronic pancreatitis, specifically the calcifications. The differential diagnosis for the branch duct type of IPMT will be your cystic tumors, both the microcystic adenoma and the mucinous cystic neoplasm. So this graphic just shows you, in this particular case, we have involvement of the main duct, but only focally. So this is the segmental version of the main duct type. Here we have involvement of the branch duct, but with larger cluster of cysts. So the differential here will be your mucinous cystic tumor. Here's a branch duct IPMT, but with multiple smaller cysts. So the differential will be your microcystic adenoma. And here you have the combined ductal type, diffuse enlargement of your main pancreatic duct, but also involvement of multiple side branches with clusters of cysts. So this is the branch duct type, where you just see a cluster of small cysts. When they are small, particularly if they're under 3 centimeters in total size, they're more likely to be benign, and you can follow these with imaging, typically with MR. This is on non-contrast CT. Very difficult to distinguish what the structure is here. You can see on the MR, T2-weighted MR, you can see multiple small cysts. And what's nice here is on the MR is that you can see the connection to the pancreatic duct itself. So this is the branch duct type of IPMT. The differential here is your microcystic adenoma. Now, here's an example of the diffuse duct type, which certainly can mimic chronic pancreatitis, except that you don't see the calcifications, right? Just diffuse main duct dilatation. Now, this is considered to be more likely malignant, so when you diagnose this, patient has to go on for surgery. ERCP, markedly dilated pancreatic duct, multiple filling defects. And the filling defects are due both to mural nodules as well as due to mucin. Here's the ampulla, which is gaping, wide open, and with mucin that was coming out of it. This is an example of the combined ductal type of IPMT. What I have in the solid arrow, this is actually dilatation of the main duct. You can see other areas of the main duct that are dilated. But look at this cluster of small cysts sitting in the area of the head, right? So this is the combined ductal type. The prognosis of the combined ductal type is similar to the main ductal type, so more likely malignant, has to go on for surgery. There are 4 predictors of malignancy that were found in this particular study. If there are mural nodules, intraductal calcifications, thick septations, and if there is marked dilatation of the pancreatic duct greater than 10 millimeters. Okay, let's move on to our neuroendocrine tumors, formerly called our islet cell tumors. And 85% of neuroendocrine tumors are actually functional. The most common type of neuroendocrine tumor is actually your insulinoma. And I always say if I had to have a neuroendocrine tumor, this is the one I would want. Why? Because by far the majority, greater than 90%, are benign. These tend to present fairly early on because of symptoms, patient symptoms, and they tend to be fairly small and essentially cured when resected. The second most common neuroendocrine tumor is your gastronoma. And in contrast to your insulinoma, 60% are malignant. These also tend to be of a relatively small size, and as you know, there is an association with Zollinger-Ellison syndrome. The third most common neuroendocrine tumor are actually your non-functioning tumors. And again, these are bad because up to 90% are malignant. They tend to be very large at the time of presentation. About a fourth will have associated calcifications. What's important to know is that on both CT and MR, these tumors tend to enhance intensely and briskly. So you need to perform arterial phase imaging if you're going to identify these lesions. On ultrasound, they are fairly nonspecific, just a hypoechoic mass. Excuse me. And so you have to look for these quite closely because when you have a tortuous splenic artery that sort of dives in and out of the pancreatic parenchyma, it can make it difficult to pick these out. But this turned out to be an insulinoma in this particular patient. Now, there's an insulinoma in this patient. This was just a hepatic cyst. And can you find it? I think that, even in retrospect, when you look at this, it's very, very hard. And this is a portal venous phase image. Well, when you look at it on the arterial phase, here's this insulinoma. Okay, so you need arterial phase imaging to identify these. What about this patient? A bit larger, hypervascular, right? There is really no significant pancreatic ductal dilatation, and this was a gastronoma. Here's a patient. What is this? This is the stomach, and you have marked thickening of the gastric folds. This was a patient with a gastronoma that was sitting right in this area. Sorry, this mouse keeps jumping. Sitting right here, causing Zollinger-Ellison syndrome. So due to the overproduction of gastrin, it causes hypersecretion of acid within the stomach and these markedly thickened rugal folds in the stomach. Now remember that gastronomas don't have to be in the pancreas, right, in the pancreatic head. 90% are located within this gastronoma triangle that is demarcated by the pancreas medially, pancreatic head typically, second duodenum, and then, the junction of the second and third duodenum inferiorly, the pancreatic head medially, and then actually the junction of the cystic duct and the common duct superiorly. And so, can you find the gastronoma in this particular case? Sure, you're looking for something that's hypervascular, that's enhancing, and here it is, sitting in the duodenum, okay? And what about this case, where on non-con, you can see that there is a calcification. About 25% of these tumors will have calcification, large size at presentation, hypervascular, and this is your non-functioning islet cell tumor, right? Okay, so what's the differential diagnosis for a hypervascular pancreatic mass? This is actually similar to the differential for primaries that cause hypervascular metastases to the liver, right? So you've got renal cell sarcoma, melanoma, particularly carcinoid and thyroid. And then there's an entity that I'll show you where you can have accessory splenic tissue that sits within typically the tail of the pancreas, simulating a hypervascular lesion. So when you look at this case, what you notice right away, there's clips in the right upper quadrant. This was due to a nephrectomy, from a prior nephrectomy. And you see multiple hypervascular lesions sitting in the pancreas. And these were all METs, from renal cell carcinoma to the pancreas. What about this case, where, again, in the pancreatic tail, you see this focal, well-defined, enhancing lesion, and when you compare the enhancement pattern, it really follows that of the spleen, doesn't it? And this was that entity, intrapancreatic accessory spleen. On radio-labeled RBC scan, you can see that there is uptake in this, and so, again, this confirms that it's splenic tissue. So some of the key points to remember about the pancreas is be familiar with the various types of pancreatitis, including groove pancreatitis and autoimmune pancreatitis. Remember annular pancreas specifically when you're looking at the differential for pancreatic head mass. Also, up to 10% of pancreatic adenocarcinomas are isodense, so don't discount adenocarcinoma even if you don't see it and you see the double duck sign. And neuroendocrine tumors typically enhance quickly